This is a 48-year-old gentleman who presented to McLeod Regional Medical Center here in Florence, where we're a trauma center. Status post a major motor vehicle collision. He was evaluated by the ED, underwent trauma protocol, and under typical ATLS protocol was started. He was hemodynamically stable. A brief history was done as part of the trauma. There's really no medical comorbidities, no daily medication. He's a very robust, active, healthy 48-year-old gentleman. Did have a very large displaced left hip fib fracture, but the CT of the head showed nothing, neck showed no fracture, and they did do a chest, abdomen, and pelvis, given the nature of the trauma, which showed a dissection and a thrombosis of the left renal artery, which I'll show you in a second, small left pneumothorax, and some small mesenteric contusions. From a vascular pulse exam, his pulses were all intact in the periphery, both in the arms and the legs. There really had no other arterial dissection or injury on any of the CAT scans. So this is just a couple of views of the CAT scan here. You can see that the right kidney is well perfused. The left is, reasonably normal, same size, but also hypoperfused there. And you see the beginning of the left renal artery, but you don't see much after that. Another picture of it here, and then this is just a coronal view. It's hard to see the actual dissection, in static images of the CAT scan without scrolling through. We didn't see much on the CAT scan other than the thrombosis. So the trauma department asked us, is there anything we can even do about this? So given he was young and stable, other than his fracture, which was fixated in the emergency room, took him emergently to the hybrid operating room, gave him some light sedation, so not intubate or anything, just some local light sedation, right femoral access, we used ultrasound for that. Placed our typical sheath. We gave him a small dose of heparin and thrombose anything with the sheath being in, but obviously we couldn't give him too much given his trauma, the fracture that was that was displaced, and also this mesenteric hematoma. Went up through the aorta, placed a 6 French 45 centimeter destination sheath. I and my partners don't routinely cross any lesions with the sheaths before we put the stents in, but it was difficult to cross this dissection and get back into true lumen, as you can imagine, with thrombus. And actually, even on one of the pictures, there may have even been a small amount of extrav in the mid portion of the renal artery. We were able to cross the lesion. Actually, in full disclosure, as my tech pulled out the wire, I was able to cross it twice. Eventually, we got through it. I got our angiogram, nephrogram afterwards, showing that the kidney actually was a reasonably vibrant kidney, and he had been ischemic now for only a couple hours at maximum, because he came straight from the field. Yeah. So we, given some of the new literature with some of the visceral vessels being better treated with stent grafts, plus the fact that this is a trauma with possible small amount of extravasation, elected to treat it with a self-expanding Viabond stent graft and size the size off the contralateral kidney on the CAT scan. Took a completion nephrogram, got a good result, closed the access, and he did very well from a vascular standpoint. Was treated with long-term aspirin, made good urine, normal blood pressures. Creatinine actually decreased throughout his course and even in follow-up. He's now been seen for over a year in my office with follow-up at 1, 3, 6, and 12 months with renal duplexes, showing normal kidney sizes, normal resistive indices, RAR is very low, and functioning well with not on any hypertensives, doing fine. So just a little bit about traumatic renal artery dissection. So currently, there's really only a very small number of single-center studies with no consensus guideline. Again, PubMed search shows about 11 pertinent published articles for traumatic renal artery dissection out there right now. It's very rare. It's about 0.05% incidence. The left renal artery is always more common than the right. It has to do with its shorter length, its angulation with traction, and how the left kidney is more mobile, obviously, with there's no liver or anything above it. There is 44% mortality. This is usually due to concomitant injuries. As you can imagine, patients are in significant trauma to cause a dissection of the renal artery, and thus they also get concomitant bowel injuries, lung injuries, things of that nature. Overall, in the literature, they really generalize the options for treatment into 4 different ways. One is conservative therapy, then open embolization, and last endovascular repair. Historically, especially when patients have contralateral kidneys, it has been taught, as somebody was up here before talking about, if you have one good kidney, kind of don't worry about the other. And that's really because historically there are some poor technical results with preserving kidney function when doing open procedures on these patients. And especially in blunt trauma, as poor to penetrating, there was very high recurrence of thrombosis and poor results. And even in a 15-year review of traumatic renal artery occlusions in 12 patients, even when you don't do anything, meaning you just leave it be because they have a normal functioning contralateral kidney, there's approximately 43% postoperative hypertension and need for nephrectomy. So although it's conservative at that time, there still is significant morbidity going forward. And this was Feliciano's comment in 1998 in the Journal of Trauma about, based on the data, they don't recommend touching the kidney if the other contralateral kidney is fine. Understanding that a reasonable number of patients might progress to nephrectomy and post-hypertension. Open repair, best for unstable patients with kidney ischemic time greater than 4 hours, especially if you have to go in for another reason, so if they have concomitant bowel injuries, liver injuries, splenectomies, those kind of things, to also do at the same time. 9 out of 34 patients regained any renal function at all, and 57% of them actually ended up with light hypertension despite a good technical repair, or even found, and a significant number of them even needed nephrectomy in the long term for hypertension. So again, not the best option. There has been embolization looked at in the literature, mostly for hemorrhage associated with the dissection or thrombosis. It does pretty well. Only 1 out of 20 develop hypertension, but that was actually treated with one medication. So in general, it's not a bad option, especially if you have hemorrhage, especially if it's off of a branch of the main renal artery. As far as endovascular therapy goes, there has been a little bit of talk about just angioplasty alone, which is obviously very poor data. There's one case study from Japan where they used thrombolysis, which went pretty poorly in the long term. And the last is stenting, which is really the best of the available data that we have. Again, this is obviously all, level 3 data. There has been multiple types of stents used, from Palmaz stents to stent grafts to wall stents and even some balloon expandable. And the follow-up in most of these have been kind of sporadic, because as you can see, the stent grafts have at least as good functionality going forward, and might protect you as well from having any type of hemorrhage. So in conclusion, endovascular treatment of renal artery thrombosis and dissection can definitely be accomplished. Stenting, by looking at all the literature, definitely has better long-term outcome. Type of stent is somewhat debatable, but especially in the area of trauma, stent graft is at least as good, and with some of the newer literature talking about stent grafts in visceral segments and renal segments having better patency, it may even be better, and also treats any potential for extravasation at that same time. So our recommendation is in patients who do not need exploratory laparotomy for another reason, if you have a complete ischemic time of less than 3 to 4 hours, or a warm ischemic time of less than 6 hours, meaning either you have partial dissection with some flow through the main renal artery, or they have some accessory renal arteries providing some flow to some portions of the kidney, endovascular stenting should be attempted, and we feel that stent graft should be used because it is at least as good data as the remainder of the stents, and also gives you the ability to treat any potential extravasation. Thank you.